Now, Professor Mohamed Seleem from National Heart Institute will talk about an important subject, central or brachial blood pressure measurement.
Thank you, Mr. Chairman. Can I have my slides, please? First, I'd like to congratulate and thank the Egyptian Society of Hypertension, the organizing committee, for this 25th meeting of the society, and special thanks to Professor Mohammed Abghani, who invited me to give this talk. Let's start about the central blood pressure, the current evidence and the clinical importance as compared to the brachial or peripheral blood pressure. If we will go rapidly, because the history of central blood pressure is also the history of measuring hypertension. And interestingly, the first recorded blood pressure in history, actually, it was central blood pressure, not peripheral, by English clergyman Stephen Hales, who measured the blood pressure from the carotid of the horse. However, after that, for the last 1.5 centuries, since the time of Professor Sipone Rivarucci, who invented the sphygmomanometer, followed by Krotokov, who described very meticulously the auscultatory classic method, which is implemented till now. We have different devices and major advances in the measurement of the blood pressure. The major driving force for the continued use of the brachial blood pressure has been its ease of measurement and the wide variety of devices available for clinical use. It's an easy, done daily, doesn't require any clinical expertise. However, we have known for over half a century that brachial pressure is a poor surrogate for aortic pressure. Brachial pressure is different than aortic pressure, which is invariably lower than corresponding brachial values. However, the vital organs, the brain, the kidney, and the heart, mainly exposed to the central blood pressure. They are sensed the central blood pressure. So there is some evidence about the importance, and recent evidence suggests that central blood pressure is also more strongly related to future risk and cardiovascular events than brachial pressure, and corresponds differently even to some antihypertensive drugs. The technology for non-invasive assessment of central aortic pressure, of course, it started invasively by using measurement by a cath, but now it is easy, practical, reproducible just by taking periphery, as we will mention, and through the pulse wave analysis route, what's called PWA, and had been validated in invasive studies and is currently available and approved non-invasively by the FDA. Systems that incorporate a pulse wave analysis is considered as complementary to brachial pressure measurements and can help to guide treatment decisions designed to prevent or reduce long-term target organ damage and cardiovascular events resulting from increased aortic pressure. Here now, it is measured separately as like office, like home, like the ambulatory, and also central blood pressure measurement non-invasively. Here is the devices used for the central blood pressure, starting by what's called applanation tonometry, which is to the left side of the screen. But now the second generation of the devices, now it's used exactly like the digital devices of the brachial blood pressure. Using different transformation algorithm and the different calibration, we can obtain central blood pressure. But personally, I'd like to describe as a central aortic pressure parameters, because it's not only one systolic and diastolic, as we will mention. The benefits of measuring central blood pressure, it's has excellent accuracy towards the aortic blood pressure, especially by the type 2 devices. It is more sensitive for detection of target organ damage, highly predictive of major adverse cardiovascular events and mortality independently of brachial cuff blood pressure, and also antihypertensive drugs, although have similar effects on the reduction of the brachial blood pressure, on the contrary, they have dissimilar effect on the central aortic blood pressure. Some of them can decrease the central blood pressure, some of them has no effect, and even some of them can paradoxically elevate the central aortic blood pressure, which has been described for the first time from the sub-study of the ASCOT, the CAFE study as the arm of beta blocker and diuretics compared to the arm of calcium channel blockers and ACE. Although comparable reduction of the blood pressure, still the outcome was better in the arm of calcium channel blockers and ACE inhibitors because of the reduction of the central aortic pressure. Here is the indices of the central blood pressure. First, we have the classic central systolic and diastolic blood pressure and the mean central pressure. We have the what's called AP, or the augmentation pressure, and we will describe this. We have the augmentation index, and this should be measured at the same heart rate, because sometimes the increase or decrease heart rate can affect these indices. The variations in the central from the peripheral blood pressure due to many factors. One of them is histological, because peripheral vessels are muscular with high collagen, while central arteries are predominantly made of elastin fibers, and progressive loss of elastin occurs with advanced age, with hypertension, with CKD, even in patients with obstructive sleep apnea, and leading to increased vascular stiffness. So it can be a sensitive marker for detection of vascular stiffness earlier than the brachial blood pressure. Also, we have what's called impedance mismatch. When the heart ejects the blood to the aorta, then it will go to the peripheral circulation. And we have what's called forward wave that come to be reflected again. And we have what's called reflected wave at the points of bifurcation. So we have this pulse wave generating what's called augmentation pressure. But in most of the time, this augmentation pressure is not so high. In most of the time, not exceeding 10 millimeter mercury. However, when vascular stiffness increased, we have this augmentation pressure to be higher than normal. Simply, the more stiff the aorta, and the more advanced age we have, the more increase in this augmentation pressure, which is simply the difference between the peak systolic pressure and the pressure generated by the reflected wave during the late systole. And also, if we will see here with the age of 20 years, we will have this reflected wave, and augmentation pressure is very low. As the patient is getting elder, age is 40, there is increase in the augmentation pressure, and with the age of 80, we have even this augmentation pressure exceeding 15 millimeter mercury, and can also increase the systolic normal blood pressure of the patient. This is what's called augmentation pressure. Here is the difference between the subjects with concomitant large arteries when the large arteries getting more stiff. Also, we have an important index of the central pressure, which is called the augmentation index. It is the augmentation pressure in relation to the general pulse pressure, which is very useful also for detection of the vascular stiffness, and could be a very important index for assessment of the good control of the blood pressure non-invasively. It is almost not exceeding 37% in males, and not exceeding 33% in females. Here is the analysis of the aortic wave 4. The augmentation pressure is the difference between P1 and P2, which is then correlated with the pulse pressure to get the augmentation index. Central pressure indices increase with aging, with smoking, with hyperlipidemia, with hypertension, with CKD, apparently with all causes that will increase the vascular stiffness. Although the evidence is so clear, however, this was not reflected in the guidelines. These are the guidelines from the European Society of Hypertension. The last one, 2018. We will expect the next guidelines to be 2024. But in these guidelines, the other blood pressure measures like what has just mentioned by my colleague about the exercise blood pressure and central blood pressure is still class 2B. Only in the guidelines, they pointed out to the differential effect of antihypertensive drugs on the central aortic pressure and the incremental prognostic value of the central versus conventional peripheral blood pressure measurements. Also, it may be of some value in patients with isolated systolic hypertension in young patients to assess the vascular stiffness, which may be sometimes in some patients at a young age due to multiple risk factors to be increased at an earlier age. There is some discrepancy, as I have just mentioned, due to what's called systolic augmentation of the pressure. So the central pressure is usually lower than the peripheral pressure. There is another very interesting trial pointing out that the higher arterial stiffness was predictive of incident hypertension, not the way around. Not the hypertension will cause vascular stiffness, because in this study, the vascular stiffness measured by the central blood pressure indices preceding the frank hypertension by almost 5 to 7 years. Very interesting study. So the sphygmocore, or the device, the second generation device for detection of the central blood pressure, these are the clinical applications as a driver for lifestyle choices, change in the regimens of treatment, to treat or not to treat some patients with borderline high or high normal brachial blood pressure, diagnosis of aortic conditions and systemic process like Ehlers-Danlos syndrome and others, and to assess for sometimes treatment adherence by the patients. In hypertension, still we have, even with good control, we have some residual risk, and some residual risk could be attributed to high central blood pressure in addition to the nocturnal non-dipping, blood pressure variability, and masked hypertension. These are the normal values of the normal central pressure. It should be central systolic blood pressure less than 112, stage 1 between 112 and less than 130, and the stage 2 hypertension more than 130, of course, lower than the brachial blood pressure thresholds for detection of hypertension. Let's take some examples. Here is a first patient, is a 53-year-old lady with 5-year history of hypertension that apparently well controlled on bisoprolol 10 milligram. But however, although this good control, this patient has LVH, recurrent attacks of transient ischemic attacks. If we will look to the radial pulse wave analysis and the aortic, this patient has good control of the blood pressure. Look here, 114/71. Everything is okay. Okay. What about the central pressure indices? You will see here extremely high values for augmentation pressure, and also for the augmentation index is about 52, very high. So in this patient, you may need to change your regimen of the treatment. You may need ambulatory blood pressure monitoring for detection of nocturnal rise of the blood pressure as reflected by increase of the central aortic pressure. Very interesting concept. If you will talk this relation between the aortic augmentation pressure in relation to the age of the patient, you have what's called vascular age. For the previous one, or for the previous lady, she is 53, by vascular age is 90. So she's a very high risk for developing cardiovascular events. Another example for a patient referred for assessment of possible cause of secondary hypertension in a lady, 38-year-old, with almost borderline treat or not to treat. It's 130/85/90. Okay, let's do the central aortic pressure indices. We will find high augmentation pressure and the high augmentation index. So the patient was referred for ambulatory blood pressure, which clearly demonstrate that mean waking blood pressure is very high and mean sleeping blood pressure also is very high. So the diagnosis of muscle hypertension is made, and the patient is placed on a much more aggressive anti-hypertensive treatment. Another important application of this central aortic pressure is during in office is the evaluation of white coat hypertension, when you will use a pulse wave analysis and you will have elevated peripheral and central blood pressure. This is true hypertension. But if you have elevated peripheral systolic blood pressure and normal central systolic pressure, you have to think twice again. This may be a white coat hypertension. Here is a very interesting trial called the B-Guide study, and involvement of the central aortic blood pressure evaluation leads to reduction about 16 to 20% of prescription of some antihypertensive treatment without any need for that, in comparison to the other arm, which has only 2% discontinuation of the antihypertensive medications. To summarize my presentation, The central pressure waveform provides information on arterial stiffness and wave reflection that's not available from standard brachial cuff blood pressure measurement. Arterial stiffness, wave reflection parameters such as the central pulse pressure, augmentation index, pressure can provide very useful information on the potential impact of the individual's hypertension regarding the cardiovascular risk, the assessment of the cause and source of hypertension, which is white coat or masked hypertension, the choice of antihypertensive treatment, including medication choice, because as I mentioned, some medications has very specific effect on the reduction of the central aortic pressure, and lastly, the assessment of the efficacy of antihypertensive treatment and the direction for further treatment. And thank you for your attention.
شكرا دكتور محمد اولا على الالتزام بالتايم and I have a question. If you have a patient, middle-aged patient, hypertensive, and the augmentation pressure proved to be high, what type of medication you would like to use? Calcium antagonists, ACE inhibitors, or what?
The best medications that will reduce the central pressure is long-acting dihydropyridines and also the RAS blockers, mainly the ACE inhibitors.
And that's why usually we add calcium antagonists now to a combination therapy.
Yes.
Floor. Okay.
Still the hard question with which patient you would push him for brachial measurement.
Yeah, it's a very interesting question.
Push.
Yeah,
Okay.
Practically.
Yes.
Yes,
to push.
practically. It's very important. I mentioned only two examples of those patients that I have to stress upon the central aortic pressure, because now it's very easy. Some still thinking that central blood pressure means only during cardiac catheterization or sometimes the sophisticated applanation tonometry, but now it's measured like any brachial blood pressure in office. So this will encourage us, all of us, if you will find patient when you come to the office with apparently controlled blood pressure and you will find target organ damage. It's very important for such patient to go for the central aortic pressure indices to assess for the vascular. This is one. The second, it's very intriguing about now used abroad about the detection of the adherence of the patients, because some patients came to you and say they are taking their medications and still they have maybe taking just 2 or 3 days before coming to you and all the months without taking anything. You will find controlled blood pressure and still you have high aortic indices, because it takes at least 2 months to be normalized or a decrease of the augmentation pressure. So, and also because the guidelines, the last guidelines still not fully scrutinize this central aortic pressure, I think with the recent meta-analysis, we will expect in 2024 more and more about the indications of central aortic indices.
Thanks, Professor Mohamed. Excellent presentation. Yes, Rafael.
I'm sorry for the interruption, but we do have some experience regarding the measurement of the central aortic pressure with the combination therapy.
Yeah.
In the study that we have run at Asr Al-Aini, the combination of calcium channel blockers and diuretics proved to have the highest effect on the central aortic pressure. Do you have in the literature similar effects of combination therapy?
Yeah, for the combination therapy, still the highest combination therapy, which has a very powerful effect on the central pressure, is the combination of ACE and calcium channel blocker, not diuretics. Diuretics may be not fairly judged in the ASCO trial because it is in the same arm with a beta blocker. And I didn't find, when I'm preparing this presentation, I didn't find a separate examination of the diuretics regarding the central blood pressure. They measured maybe neutral. But for the best combination is the long-acting dihydropyridines, of course, due to high efficacy regarding the vascular stiffness. And the second is the ACE inhibitors.
Thank you.
Thanks, Dr. Mohamed. Excellent presentation. Just one question.
Sorry. Sorry.
Yeah, هو sample clinical question. In hypertensive patient with compelling indication for beta blocker like ischemic heart disease, would you consider the in management follow-up blood pressure should be with central pressure in such situations, since you said that there is a paradoxical effect of beta blocker in central pressure? I want also to know why it is paradoxical, related to DPLNT or something else.
Yeah, for beta blockers specifically, those beta blockers like atenolol with prolonged diastolic time, the reflected wave will be much higher. But with the newer generation of the beta blockers with which have some vasodilator effect like nebivolol, this evidence is very weak. So in such patient, I recommend to give the new generation beta blockers like nebivolol.
Shukran, Dr. Mohammed. Thank you very much.